This is Blood and Cancer, the official podcast of MDH Hematology Oncology, where we bring you interviews with leaders in the fields of clinical hematology and oncology. I'm the voice of MDH Podcasts, Nick Andrews.
This week on Clinical Correlation, judging patient compliance and how provider biases can influence it.
And I'm joined this week, as I always am, by Dr. David Henry. It's our 58th episode of Blood and Cancer, and we are still talking about some of our unbelievably great and useful interviews that we got from the 2019 meeting of the American Society of Hematology. And we have another one coming up, but first, talk about clinical correlation. Following the interview today, Dr. Ilana Yurkowitz will talk about patient compliance. And we'll get into all of that. But welcome the host of the show and the host of the interview, Dr. David Henry. Dr. Henry, have you avoided coronavirus and the flu and any respiratory illnesses that are just going around everywhere?
So far so good. It's certainly, as we record this evening, it's on the rise in concern and of course on the rise in cases. A little update we had weekly at our hospital of what's going on. It's actually not quite as mortal as influenza, which kills thousands every year in this country. It certainly is bad and needs to be respected, but flu is a little worse.
Are you saying that there's perhaps a little bit of a hype machine that's running away? Is that something?
A bit of a hype machine virtually every evening on the news. I don't fault them awareness, but boy, it'd be nice to put it into context.
Get your flu vaccine is what you're saying.
Get your flu vaccine. Still time.
Absolutely. I completely agree. And I want to be on record as saying I was the first person to come up with the most important thing about coronavirus is that we pair it with some Lyme disease. Ha! Oh, somebody stop me. Oh my goodness. Yeah,
that's good.
Oh, thank you. I appreciate
I'll use that.
Yeah. You know what? Just make sure that you cite me in the works cited in bibliography. I appreciate that.
Maybe.
So let's get into clinical correlation. Dr. Ilana Yurkowitz has a bit of a heavy anecdote for us this week. It's about patient compliance. Dr. Yurkowitz talks about how she had a patient who appeared like they would be compliant, but this patient wasn't quite compliant. And it's about how important it is to address not that you think the patient will be compliant, but that the patient's needs are being met and that you're communicating clearly.
Consciously and unconsciously, I think we all do this in the office. I'll say to a patient, now, we're going to do this, that, and the other, and I'm letting you go home with all this because I trust you. You're aware of what's going on. You have a phone. You have my direct line. And if this, that, and the other happens, you will contact me. And as opposed to sometimes I'll say, I don't trust you for various reasons to do what I'm saying. And these are toxic, potentially morbid, mortal therapies. So I'm going to do such and such in the infusion center or in the hospital because I don't trust you.
That's one of those things that I think is just such a difficult thing to assume about a patient. And it just keeps preaching this idea, the paradigm shift over the last decade or so of individualized medicine. So that's coming up after our interview. Our interview guest this week, as we were at the ASH meeting, we're going to continue talking about diseases like CLL. And I think this is one of the more educational interviews that we did. And it's something that there are short-term and long-term things to think about.
Yeah, this was a really nice interview. We have a lot of ongoing follow-up from our ASH meeting. And this was Dr. Anthony Meadow and his fellow Dr. Roker from Sloan Kettering in New York. And CLL is increasing in my experience and the numbers I see because the population's aging, and this happens to a senior population. And the nice thing about the interview and with the theme of the meetings was FCR, a chemo which we've used, a chemo-based regimen we've used for years, may be dead thanks to targeted therapy. He's going to mention in the interview, and as will she, the BTK inhibitors, acalabrutinib, that is a nice addition to ibrutinib and may be better for reasons he'll get into, paired with or without some CD19/20 antibodies like obinutuzumab. And then venetoclax, a BCL2 inhibitor, comes into the discussion with the patient and a pill that might be used as an outpatient to even enhance their responses and do better. So this is really a hot time with nice therapies that are effective outpatient CLL.
Yeah, and that's obviously, and you and I were talking before we started recording tonight, FCR going away. I think there's a lot of hematologists and clinicians around the world high-fiving each other that's not in the rotation.
Don't let it hit you on the door, hit you on the way out. This is good to see it go.
Absolutely. Well, Dr. Henry, I hope that you and I our immune system stays strong amid the war that's going on, and that our brains stay strong amid the hype war. And I appreciate you joining me, as always, coming up. We've got this great interview. Stick around.
Stick around. Talk to you next week. Thanks, Nick.
Thank you.
Welcome to this podcast. I'm Dr. David Henry, your host of Blood and Cancer. You're listening to on the mdedge.com/hematology-oncology webpage from our electronic journal, where this podcast is present, and with archived issues from all through the year. We post each Thursday morning about interesting topics for practitioners in hematology and oncology, and we're broadcasting this week from the American Society of Hematology meeting 2019 in beautiful, sunny, warm Orlando, Florida, where those of us in the Northeast are very happy to be here. And also from the Northeast, we have two wonderful young physicians from Memorial Sloan Kettering, Dr. Anthony Mado and Dr. Lindsay Roker, who are specialists in CLL, and I want to welcome you both to the podcast.
Thanks so much.
Thank you so much.
And so in CLL, I'm a general practitioner, and so it's very common a primary care doctor will see a patient for his routine evaluation. We'll say he's 75, he's fit, and his CBC comes back 25,000 white count. Of course, the primary care is quite concerned, and may or may not, increasingly they do, pick up on the flip, what we call the flip differential. So, gee, it's a lot of lymphocytes and not so much neutrophils. Hemoglobin's okay, platelets are okay. Patient comes to me, and I send the resident in who comes out and says, yes, you know, we ought to send a CD5, 19, 20, 23, and they all come back positive. And I say, well, this is CLL. And the resident says, well, what's our initial workup beyond what we just did? So what would you say beginning with this new patient?
So our initial workup is often a FISH, which we're looking for deletion of 13q, 17p, 11.
And those are bad.
Exactly. Mm-hmm. Then trisomy 12, which is kind of neutral, and then 11q.
We also perform next-generation sequencing and specifically look for mutations in TP53 as well as IGHV mutational analysis to recognize whether a patient is mutated or unmutated.
So I know in my entire life in oncology, everybody says TP53, that's bad. And so the IGVH mutated, unmutated, which do you prefer?
So mutated tends to be disease that responds a bit better to therapy, and that's kind of how we think about it.
And I always say to this patient who now, of course, use leukemia word, and you have to console them that it's not what they think of kind of leukemia. And this is a very good patient we're posing. And he will then say, well, when do you treat me and with what? I usually say, I treat you if it bothers you or bothers me. Bothers you, fevers, chills, night sweats, lumps or bumps in your neck, and your liver and spleen are large, or the rest of your CBC is a mess, or your creatinine's high from lymph node swellings blocking your ureters. Would you say about the same thing in this patient I've posed?
Absolutely.
All right. Well, maybe he goes away and he gets a couple of second opinions, goes to Sloan Kettering, hears the same thing, and then comes back and treats in Philadelphia and progresses. So now he's getting CBC problems. He's getting symptoms. Lymph nodes are swollen. CAT scan shows big liver spleen. What's your first therapy? We'll say he's IGVH unmutated, and maybe if you want to put in a couple of FISH cytogenetics that you don't like as well.
So if he's, in our algorithm, if he's IGHV unmutated, that's basically takes chemoimmunotherapy combinations off the table, regardless of whether he's young or fit.
This would be the FCR type regimen.
FCR, BR, even I would argue obinutuzumab chlorambucil. So if he's unmutated, you're unless there's some extreme reason why you shouldn't be getting a novel agent, you're on a pathway to receive a novel agent as first therapy.
Okay.
The choices keep expanding, and they expanded here at the ASH meeting. So the standard options are ibrutinib plus or minus obinutuzumab. It has two indications in the frontline setting. Ibrutinib was first novel agent approved in the frontline setting. You also have an option of venetoclax plus obinutuzumab. That's the CLL-14 regimen.
And that's approved in first line.
That's approved, time limited, 12 months of therapy, everybody stops. And then the third option, which is the newer option that's just received FDA approval within the month and NCCN guidance as a preferred category, would be the BTK inhibitor acalabrutinib with or without obinutuzumab. So 3 different novel agent-based therapies available to patients with different adverse event profiles, different schedules, different benefits to the approaches.
So it requires a discussion. At the moment, you wouldn't say, well, this is 1, 2, 3, this is 1, 2, and 3, and we may or may not choose 1 or 2 or 3.
Would you? I would. We have a pretty similar practice style, and I think speaking for both of us, we don't have data to tell us which to choose. They're all winners, is the way I like to explain to patients. It just depends on do you have the time for a dose escalation? Do you have the time for infusional therapy combined with a pill? And then you take into account comorbidities as well as the adverse event profile of the agents themselves and help patients to make a decision.
Can you comment a bit on the dose escalation? Let's say his white count's 100,000, and you're going to use venetoclax. I know in our practice we kind of freeze and shake a little bit because things might go wrong. How do you handle that 100,000 patient?
So when they're high risk for TLS, bring them in the hospital.
Tumor lysis syndrome.
Tumor lysis syndrome. Bring them in and close monitoring with fluids is definitely the safest thing to do.
You admit them?
We do.
Yeah, okay.
Yep.
And that's what the label suggests we should do.
And you step up, what would be your starting dose, and how often and when would you step it up?
So it's 20 milligrams to start, and then you have an escalation every 7 days. Okay. So
with this oral agent?
Yeah, exactly. So it takes 5 days. Sometimes those really high-risk patients need to be in-house for 48 hours once a week for the first couple weeks until their white count really comes down.
Also want to comment, though, about that regimen and how the antibody really improves the risk status before you have to give the venetoclax.
So debulking with obinutuzumab certainly allows fewer patients to need...
CD20 agent.
Exactly.
Okay.
So that anti-CD20 really clears out a lot of the white count and hopefully melts away some of the nodes. So it's relatively rare to have a high TLS risk patient in the frontline setting after that obinutuzumab.
And that could be done outpatient infusion center before the venetoclax admission?
Exactly.
Okay, all right.
And once that white count comes down, then if you follow the guidance in the label, you don't have to admit the low or medium risk patients. That could be done in the clinic safely.
So it depends as you debulk where you might go next. Okay. Now, what do you worry about? Can you say to him something about how long this might last, how long you would need to be treated, and what are you watching for relapse?
Specifically the venetoclax therapy?
Yes.
Well, we've had updated data here at the ASH meeting. Everybody gets a year worth of therapy, but we now have updated landmark 36-month progression-free survival. It's approximately 82%. So you have an 82% chance of being in remission 3 years after you start the therapy and not requiring another therapy, which is excellent results given the fact that you've only had 1 year of therapy in total.
It's terrific, especially in an aging population. You've got things out to 3 years. Similar thoughts without, of course, the debulking need and the TLS for the acalabrutinib or the ibrutinib approach. How does that be different in terms of how long you would treat and your expectations for remission?
So ibrutinib and acalabrutinib are both treat to progression kind of approaches. So that's more appealing for the patient who either really doesn't want to come into the hospital or doesn't want to think about an infusional-based therapy. For some people, that pill a day is just a lot easier.
Sure.
And those are kind of the patients that we think about it. Of course, it's important to think about that side effect profile and make sure that it's the right treatment for the patient.
And that reminds me to ask you pills. So some of our patients, like lenalidomide, we put them on an aspirin. Do these patients need to be on an antiviral, an antifungal? So there's no ongoing in the background medication needed to watch for side effects?
No mandated prophylaxis antimicrobial-wise for this patient population.
Okay. And then I guess just briefly, he gets his 3 years and he comes back in progressing. So, Lindsay, the IgVH, would that change as this patient comes in and relapse?
No, but the others can. So your FISH can change, your P53 mutational status can change.
Okay. Hate that P53. Okay. So now we're P53 mutated, we're abnormal, and he's in relapse, and he's had, let's say, that year of venetoclax therapy, and he's out 3 years, and boom, a relapse. Now what's your therapy?
You just asked the $1,000,000 question. You'd be preparing for the plenary session if you had that answer.
Okay.
Yeah, so we don't know. The two big choices for patients in this situation would be to retreat with the same regimen or to switch to a BTK inhibitor.
Okay.
And we have limited information about retreatment, in particular with venetoclax, particularly in the frontline setting. We have some emerging data about BTK inhibitors post-venetoclax. The good news is that even in the absence of retreatment data, we have data that we'll present in the afternoon session today that really suggests that if you've never seen a BTK inhibitor before Ven, they work well after Ven. So that's a safe bet. Response rates exceed 80%. It is also very reasonable to think about retreating with the same regimen, and over the next year we'll get a lot of information from that same CLL14 about retreatment data.
Boy, really excited. For someone who goes back to chlorambucil days, this is really spectacular, exciting that we have new agents, different classes. You can switch to different classes of relapse. I guess I want to bring us to a close by mentioning the king, speaking of old therapies, rituximab, been out since the mid-90s, has, of course, expended its patent, and there's two biosimilars. Here we are in December 2019. One, I think, is approved, another's about to be, or maybe both are. Have you had experience yet with, and do you have a problem using rituximab biosimilar?
I have not yet used a rituximab biosimilar. I suspect many of us will use these agents as they are reviewed by our P&T committees, and
somewhat insurance-driven, probably.
Somewhat insurance-driven, similar to the colony-stimulating growth factors, and the decisions are made for us. I personally don't have a major problem with them. I think that from what I know about biosimilars, which is sort of a medium amount, the FDA has gone through a lot of thoughtful considerations in determining what is a biosimilar, what is the approval pathway forward, and I feel pretty comfortable that if FDA signs off on the rigorous testing to prove an agent is biosimilar, that it could be acceptable for clinical practice.
And that is my strong feeling. I think we're hoping to see some improvement in costs based on biosimilars, and they really have an incredibly strong vetting process for the FDA. So I think we'll bring it to a close and really thank Anthony Mado and Lindsay Roker, both CLL specialists, Anthony, a young rising attending, and Lindsay, a very young rising fellow. Thank you both for stopping by to talk about CLL here at the ASH Meeting 2019 in Orlando, Florida. And we will have show notes on our mdh.com/hematology-oncology webpage highlighting the bullet points of these two great young investigators. Thanks so much for coming by.
Thank you so much.
Thank you.
You're welcome.
Thanks, Dave.
And that concludes the interview portion of our show this week. Don't forget there are robust show notes available wherever notes are found in your app. We'll be right back, and when we return, Clinical Correlation. Welcome back to Blood and Cancer, the official podcast of MDH Hematology Oncology. I am Nick Andrews. It's time now for Clinical Correlation. Dr. Ilana Yurkowitz.
I'm Dr. Ilana Yurkowitz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. Compliance. It's a term in medicine that refers to a patient going along with, or complying with, the doctor's recommendations. It's actually a somewhat controversial term now, as to some it implies, incorrectly, that the doctor knows all and that a, quote, good patient simply has to accede to it. Beyond that, I wanted to talk today about another reason it's controversial, and that is because it's really difficult to predict. Oncologists meet a person, ask a few questions about who they are and what they do, and develop a mental picture that assumes more or less compliance. That mental picture greatly influences what treatments we do and do not offer. In cancer especially, treatment courses can be long and complex. Patients need to come for regular doctor's appointments, blood tests, scans, and therapies. And sometimes patients very well can't comply because life is hard, because they can't afford it, or because they're the caregiver themselves for a sick family member and can't get away, or because they're working and can't travel to appointments. There's a litany of reasons, some we can help with, and others we can't as much as we want to try. But as with something I've discussed previously on this podcast, which is the concept of fitness, the concept of compliance is another black box that we often judge up front, but that is really difficult to predict and subject to bias. Oncologists can assume more or less compliance because of someone's age or gender or ethnicity or what they do for a living. And the stakes are incredibly important because if you think someone can't make their appointments, you're not going to offer the optimal care. I'll share one story where my instincts were wrong. I had a patient a while back with leukemia. We gave full intensive chemotherapy in the hospital because she seemed like a patient who would have high compliance with the rest of our planned regimen. She was a manager at a company, had a lot of responsibility in her professional and personal life, and we assumed that same mentality would apply here with her new cancer diagnosis. But once she left the hospital, she missed appointment after appointment. She canceled at the last minute. She ran late to blood draws or just didn't get them. She was well off financially, lived close by, and had a supportive family. What was going on? What was going on, I learned later, was a profound denial based on fear. And as much as we tried to address those fears, her compliance remained low. She didn't come to receive treatment, and she ultimately passed from her cancer. I tell this story because it humbled me. We cannot predict compliance based on superficial factors like what someone looks like or what they do for a living. It requires a much deeper look into someone's life and psyche, and even then, we can still be wrong. The consequences are real, and the stakes could not be higher. I share this story as a reminder to treat every patient with the seriousness they deserve. Thanks for listening, and I hope you'll tune in next time for Clinical Correlation.
And that's a wrap on this episode of Blood and Cancer. It's time now to give credit where credit is due. The host of Blood and Cancer is the editor-in-chief of MDH Hematology Oncology, Dr. David Henry. The Clinical Correlation segment is written, recorded, and produced by Dr. Alana Yurkowitz. All MDH podcasts are produced by our editor-in-chief, Dr. Ivan Aransky. Executive editors Mary Ellen Schneider and Kathy Skarbeck. Multimedia editor Terry Rudd. Social media is produced by Kyla Clark, and I am your audio engineer, audio editor, and the voice of MDH Podcasts, Nick Andrews. You're listening to Blood and Cancer.